Hey, welcome back to Not So Complicated. And have you ever stared into the histopathology slide, one of the histopathology slide, and wondered what the hell am I looking at? Yes, I can relate that too. So I have brought this how to read pathology slide guideline, step by step guideline, since this is a global problem. So let's begin. There are very much steps. Step 1 is magnification, then we will talk about staining, then tissue type, then what is the objective of looking. So by the end of this lecture, you will be able to diagnose the disease with clinical symptoms and just by histopath slides, looking at the histopath slides. And also at the end of the lecture, I have a special gift for you, that is 32 diseases with specific histological findings. So stay tuned and let's begin. And in different, like in magnification, magnification like 10x, 40x, 100x, and then 400x, there are different visuals that we can see. So at 10x, there are very high yield points, like we can see entire tissue architecture, right? So this is the entire tissue architecture that you can see. Let me change this color. Okay, so here you can see okay, I have to change thickness. So here you can see this is the entire tissue architecture that you can see, right? And this is the lumen right here. This is another tissue architecture. So you can see entire tissue architecture in high like 10x point, and then organ level or lobular arrangement visible, that is full glomerulus if it is a kidney, and then entire crypts and ducts, and also bronchioles. You can see these are also crypts, like this is the figure of colon adenocarcinoma. You can see the entire tissue types, infiltration of these cells, these cells right here you can see, right? So individual cells are not very distinct, nuclei are small dots. These dots, every blue dot in here is a cell. So that is how our tissue, like a slide, looks like in 10x. You have to remember the spectrum that visualize, right? So in 40x, there is, you can see individual cells clearly. Here you can see individual cells clearly like this, right? So these are black dots with high nucleocytoplasmic ratio right here. You can see, right? These are in 40x, that you can see individual cells clearly, but not subcellular details. Like there is nucleus, but you cannot see nuclear loss in that, and also chromatin stains like that. You cannot see that, right? This is also vague. We can definitively see this in our 100x. There is nuclear morphology becomes apparent but not clear. Shape, size, and hyperchromasia can see. We can see these are dark blue in color relative to other cells in here, right? So these are pathognomic cells right here. So this is hyperchromasia. And also shape and size, there is increase in shape of nucleus, size of nucleus relative to the shape of the cells, right? That is high nucleocytoplasmic ratio. So that signifies that the case is malignancy. And also it can assess cytoplasmic characteristics, presence of inflammation and necrosis. There are no signs of inflammation here, because if there were signs of inflammation, there would be infiltrative cells of neutrophils, like neutrophils and macrophages kind of cells would be there, and necrosis, there would be specific lesion kind of this. And this is how the 40x looks like, right? So in 100x, what actually we can see is that there is a very small field of view. It is a very small field of view, and you can see detailed morphology of individual cells, like nuclear details are crisp right here. You can see this detailed morphology, right? There are nucleus right here. You can see nucleoli are visible, but nucleoli and chromatin texture are more visible in 400x, that is typical. And in colon adenocarcinoma, you can see there are chromatin texture too. These are chromatin texture here, right? I have put the example of colon adenocarcinoma, just the example, right? And then we will talk about the objective and example case study, how we will tackle the case, right? And also we can identify mitosis. There are a lot of mitotic figures right here. That is signifies that this is an active case of malignancy. Here are these all are mitotic figures, and also along with these cells right here, which has hyperchromatic nuclei, and also that can present atypia and also anaplasia, bacteria, protozoa, cell inclusions. And these 400x right here, this is very significant in here. So high yield points here is that you can see individual cells in very high detail. You can see nuclei. These are nuclei right here. And then nucleoli, cytoplasmic granules, and cell borders are clearly visible. So this is the case of colon adenocarcinoma. For example, let's take this cell, right? This is the cell, and in the periphery there is a nucleus right here, just like this cell here, and that means that there is a signet ring stage in colon adenocarcinoma. Signet rings are very much common. You can see all the peripheral pushing due to vacuoles or cytoplasmic growth, peripheral pushing of nucleus, right? This is very highly detailed. You can see like that. These are signet cells. So that is how nucleoli and nuclei are seen, and also cell borders. There are visible clear demarcation of cell borders right here, right? So this is ideal for examining cell morphology, and then size, shape, atypia, as I had talked earlier, and then inflammatory cells like mitotic figures. There are no inflammatory cells here, and also in mitotic figures there can be like there would be like this kind of mitotic figures, these dots, these cylinder shaped cells. These are mitotic figures if it is an active case of malignancy. This is not an active case of malignancy right here. And also in glomerular detail, if you look into the kidneys, you can look the glomerular detail like capillary loops and mesangium, and fungi and larger microorganisms would be seen if it was a case of histoplasmosis or blastomyces infection. And in parasites like plasmodium in blood films can also be seen, right? So this is how the magnification is debunked right here. So the next step is our staining. There are different types of staining, and in different stains there are different features of cells. The same cells have different features in different staining, right? So we have to know how the cells would look like, how the nuclei would look like in different stains. So I have put this there. We can talk about H&E stain, which is the most common stain, and PAS, periodic acid stain, silver stain, GMS stain like, and also Zell-Nielsen stain as in AFB, Congo red stain, and Zimsa stain. So we'll talk about this. In H&E stain, that is hematoxylin and eosin stain, this is the most common staining method, and nuclei appear blue or purple. This all blue or purple things, these dots, these all are nuclei. Okay, that is how you remember. And also in cytoplasm, all this pink structure is cytoplasm. All these pink structures is cytoplasm, and these out of the cells, these are also cytoplasm, and these dot cells are nuclei. Structures are nuclei, the most common, and it is very good for seeing basic tissue, inflammation, and cell types, right? And in inflammation, there would be infiltration of hyperchromatic neutrophils, right? Hypersegmented neutrophils, hypersegmented polymorphonuclear cells would be there, and you can visibly see that, right? And in PAS stain, that is periodic acid skiff stain, there is bright pink color seen. That is magenta color. You can see this bright pink color right here, right? So if a histology slide, you should not get confused with this H&E stain and PAS stain. So in PAS stain, there is bright red color structures, and they are usually glycogen or mucins, fungi walls, and also basement membranes. It is typically seen in the cases of diabetic glomerulosclerosis, Whipple's diseases, macrophages, and fungal walls. So we stain by PAS in case of fungal infection, and also Whipple's disease and diabetic glomerulosclerosis. The another stain here is silver stain, and silver stain has different examples of it, which one of them is GMS. And also then in GMS, there are in silver stain, you can see black structures on green or gray background. You can see here, these are black structures, right? These strands are very black structures, and there is brown or gray, greenish brown kind of background here, right? So that is silver stain. And fungi like pneumocystis and also histoplasmosis, you can see reticular fibers here. These are reticular fibers. And in silver stain, it is the most commonly done for fungi, and fungal walls stain black, common in opportunistic infections, as there are very common infections in AIDS, like Candida albicans, you can do silver staining. The another type of stain is Zell-Nielsen stain, which is done for acid-fast bacilli. And in this case, there are red bacilli. You can see pinkish red bacilli here, and the background is blue, light blue. This is blue background light here, right? So it is usually done for mycobacteria and like tuberculosis and Mycobacteria leprae. And acid-fast organisms are red, useful in granulomatous infections, right? If the question is presenting granulomatous infections features, then it is most probably like this slide. You can easily recognize this slide now, right? So, and in Congo red, there are two types, under light and under polarized light. There are two stainings. This is under polarized light and this is under light. And under light, there is reddish structure seen. In Congo red staining, these all are reddish structures, right? But in polarized light, there is apple green birefringence seen. In this, it is so beautiful to look at, right? In polarized light, there is apple green birefringence seen, and also there are usually typical examples are amyloidosis, and amyloid deposits in kidney, heart confirm with birefringence. That is how it occurs. And in Zimza stain, you see blue or purple color nuclei. You can see these all blue or purple color nuclei, and then cytoplasm is pink. There is pink cytoplasm. You can see this is Zimza staining, right? And Zimza staining is usually done for blood smears, parasites like malaria, leishmania, and H. pylori. There you can see lymphocytes, monocytes, parasites, and good nuclear detail. There are different kinds of cells in here. You can see. That is how staining differs the cellular characteristics and architecture, right? So that is how. So we have to first identify magnification, which magnification it is, then the staining, which staining, and in the features, the different features and different staining we have debunked. Now you can know. And now we will talk about tissue type. What tissue type looks like what, right? So in epithelial tissue, we have the general look is that there are sheets or layers of closely packed cells. You can see these are sheets or layers of closely packed cells right here, right? And also there is minimal extracellular space like this. There is minimal extracellular space. There is no vacant space, and clear organization is there. You can see very clear, and lining surfaces and forming glands like here. These are lining surfaces, right? These are lining surfaces here, and may have specialization like cilia, microvilli, or goblet cells. You cannot see here because this is not the case like that. And in what to look for? What do you look for when you look at epithelial tissue? You have to look for apical surface, which is free edge facing the lumen. It should face lumen, and basement membrane at the base like this. This is the basement membrane here. And then you have to look at the cell shape. If it is squamous or flat, and cuboidal, the cell shape is cube, and in columnar, the cell shape is tall. Here it is columnar. Sorry, squamous. Stratified squamous. Like, you cannot get confused with that because like there are two cells in two different layers. So that is why it is stratified, and cuboidal shapes are there. Okay, nuclei are aligned in a row. You can see this is a single row. Nuclei are aligned in a row. That is how we recognize our epithelial tissue. And in connective tissue, there are different types. Like there is dense, irregular, and loose. Okay, the collagen is different in different structures, and also glycoproteins can be there. And in general look, there are fewer cells in connective tissue. Lots of extracellular matrix. You can possibly look at that. There are a lot of extracellular matrix, right? And also looks loose or dense depending on fiber content. It depends on fiber content to distinguish between dense or loose. Here it is very loose, right? Because there is less dense fiber content, and there are a lot of fibers here. These are a lot of fibers, so that contains dense, and also this is loose, right? There is regular fibers here. You can see regular structures, and there it is irregular structures. Right there, it is very haphazardly arranged. And common fibers, the collagen is seen pink colored, and elastin is thin, wavy. Here you can see this is wavy, and this is collagen in pink color, and reticular like fine. Reticular looks like this. This is very fine, right? And it contains fibroblasts, macrophages, adipocytes, mast cells, etc. And what to look for? What do we look for when we look at the connective tissue? So we look for loosity. Loose connective tissue is in scattered nuclei, thin collagen strands. And in density, we look for tightly packed pink fibers, few cells as in tendons, right? And in adipose tissue, we look for empty round cells with nuclei at the periphery. How do adipose tissue looks like? These are adipose tissues, for example, and this is very back end, but there is nucleus in the periphery like this. Nucleus are present in the periphery, and remaining part of the cell is vacant in adipose tissue. That is how it looks like. And also there are septal. There is septa in this different regions, and there are another cells here, right? That is how adipose tissue looks. And in cartilage there are lacunae with chondrocytes, and bone there are concentric laminae, osteons with central Haversian canal. So that is it. And in muscle tissue, the general look is elongated fibers like this. You can see very basic elongated fibers like this, and striations there are striations in skeletal and cardiac fiber, and nuclear arrangement is the key. What to look for? Skeletal muscle, you have to look for long striated multiple peripheral nuclei right here. And cardiac muscle, you have to look for striated branched central nuclei with intercalated discs, right? And in smooth muscles, there are no striations. So how do you recognize? You don't have to like recognize this between these three cells. For example, a patient comes with symptoms of muscle weakness. You don't have to like generalized muscle weakness. You don't have to think if it is cardiac muscle or not, or is smooth muscle or not. If the person presents the leg weakness or extremities weakness, it is obviously the case of skeletal muscle, right? So it is not the case of cardiac muscle or smooth muscle. If there is a case of gastric upset, it is a case of smooth muscle. That is how it is very easy. We'll talk about how the objective varies, right, in the upcoming steps. So the last tissue type here is nervous tissue. It looks like, in general finding, it is large pale staining neurons. You can see pale staining neurons with visible nucleolus right here, and then surrounded by numerous small glial cells. These all stained cells are glial cells right here. These all are glial cells, and often appears spongy due to neuropil network of axons, dendrites, etc., and glia. And what to look for? We have to look for neuron, which is large cell body. This is the cell body. Pale nucleus, prominent nucleolus, which is bull-eye. Here, this is a little bit dark. So glial cells is small dark round nuclei. You can see these all are glial cells. Glial cells are supporting cells for neural system. And cerebellum, it is layered with large Purkinje cells. And in spinal cord, there is butterfly-shaped gray matter, peripheral white matter seen. That is how we see the nervous tissue. Now let's talk. This is where the main important things appear. What is the objective of looking? So in step 1, you have to analyze the clinical scenario. You have to ask yourself what system is involved. For example, neuro, right? So if there is vestibular tinnitus or like that kind of things, it is a case of neuro. And if there is symptoms like diarrhea, constipation, it is a case of GI, right? So you don't have to get confused with neuro or breast or bone, and the differential diagnosis narrows down due to these symptoms. And if there is a lump in the painless lump in the right side of right breast, let's say, so you don't have to get worry about bone, GI, or neuro. How do they look like in tissue, in histopath, right? So you have to focus just on the breast. And what is the dominant process here? Is it mass? Is it inflammation, bleeding, or functional loss? If there is functional loss, there can be fibrosis or degeneration. If there is bleeding, you can possibly find out like anemia. If there is inflammation, there are the inflammatory infiltrates there. And if there is mass, you can suspect tumor, malignancy, benign, and tumor features can be there. And in acute, days, chronic, months or year, is it sudden onset or not? You can also look at the time course of the clinical symptoms. So we have to narrow it to 2 to 3 system-based differentials before you even look at the slide. Now you have differential diagnosis. We'll talk about this in a very much example in the upcoming example, so you get clear picture of this. And also in step 2, then you have to define the pathology type. Now, what category of pathology am I expecting, right? So is it mass, nodules or lump? If it is the case of mass, nodules or lump, it might be a case of neoplasia. If it is fever, pain and swelling, it might be inflammation, acute or chronic. Bleeding or anemia, there might be vascular lesions or necrosis, right? And if it is a case of functional loss, there may be degeneration or fibrosis. And in autoimmune signs, there may be granulomas or lymphocytes, right? So know what class of findings you expect histologically. Now you know what class of findings in these categories you have there, right? Now, step 3. Now you have to observe the histology slide. Now ask yourself systematically, what tissue is this? Is it epithelium, connective tissue, muscle, gland? In gland, there are a lot of lumen. If there is lumen, it is gland. You can remember like that. And nerve. What is the type of tissue? Normal architecture is intact or distorted. What is it? And what is happening to the cells? If there is increased nuclei, is it proliferation? If there is enlarged and irregular nuclei, is there is nuclear atypia or cellular atypia? Is this the feature of malignancy or tumor neoplasia? If there is multinucleation, necrosis, mitosis, is it? So that is how we ask ourselves. And what is in the stroma? If there is fibrosis, it will look like pink collagen, dense pink collagen. Are there inflammatory cells? If there are neutrophils, it might be the case of acute inflammation. If there is lymphocytes, it is chronic inflammation. If there are plasma cells, it is autoimmunity. And if there are giant cells or granulomas, it might be the case of tuberculosis or sarcoidosis, right? What are the special features? Are there any special features in this histology slide? Is there any gland formation? If there is gland formation like lumen, it might be adenotype tumors. Are there keratin pulse? This might be a case of squamous cell features, right? Are there mucin lakes? It might be the case of adenocarcinoma. Are there rosettes or neuroendocrine patterns? They specify like Flexner, Wintersteiner rosettes or Homerite rosettes. There are different features in different diseases, like you can remember like that. So what is the goal of observing the histology slide? We have to match expected pathology class with slides visual patterns. Now we have matched, right? So what to do the next? And in step 4, we integrate slide back with the symptoms. So now that you know what you were looking for and what you saw on histo, does this confirm one of your diagnostic differentials? It must. And if it doesn't, reconsider the pathology type or system. That is how you loop forward again and again until you go to the diagnosis. That is how it happens. Do the tissue changes explain the symptoms? This is another crucial question that you have to ask yourself, right? So if it satisfies you, you might have raised the diagnosis, and if it doesn't, you haven't. Let's talk as clinical symptoms like one disease. And before that, there is bonus pattern tags to train your eye. This is bonus. Like if there are gland-like spaces, it is a case of adenocarcinoma. If there are round blue cells, it might be lymphoma or small cell disease. If there are seeds of pleomorphic cells, it is high-grade carcinoma. If there are central necrosis and inflammation, this might be abscess or ulcer. You have to remember this. You have to remember all of these to have a broad knowledge of this, right? So if there is granulomas and giant cells, TV, sarcoid or Crohn's disease might be there. And if it is a case of collagen or few cells, it might be fibrosis or scar. And if there are clear vacuolated cytoplasm, it may be lipid, mucin or glycogen-rich tumors. That is how you think. This is the thing. You have to learn how to think, right? Let's talk about a clinical example case. So, for example, there is a 45-year-old woman, and she has a painless lump in the right breast. There is no fever, trauma, or skin infection, and there is family history of breast cancer. Now, let's go by the steps that we have talked earlier. So, what system is involved? It is breast, which is, it might be epithelial or granular origin. Just by the system involved, just by knowing the system involved, the diagnosis is narrowed down to just epithelial or granular origin, right? So what is the time course? It is a chronic, weeks or month maybe. And what is dominant process? There is mass forming lesion. There is a lump, right? There is a mass forming lesion. So what is the differential before seeing slide? It might be the case of invasive ductal carcinoma or fibroadenoma or phylloid tumor. So expected pathology class is neoplastic, probably malignant, right? So let's talk. And in step 2, define the pathology type. Clues like painless lump, older age, and family history push us toward malignant neoplasm, not only benign neoplasm. So now we should be prepared to look for infiltrative tumor cells, desmoplastic stroma, loss of architecture, and nuclear atypia. These are the features of malignant tumors, right? So we have to be prepared ourselves to look at that in the histological slides. Now step 3, we do the histological slide observation. Let's look at the slide as a pathologist would. What tissue is this? We see glandular breast tissue right here. How to define this as glandular? This is a small lumen here, right? These all are lumen. This lumen would be larger if it was a case of normal histology, but they are not large, right? So there is lumen compression due to the ductal cells here. So we see glandular breast tissues, but normal lobular glandular arrangement is disrupted, as I have said earlier. So tissue is breast epithelium, which is also distorted. What's happening to the cells? Let's observe. We observe densely packed ducts, as I have talked. These are the ducts, and there is very densely packed. It is densely packed in an intensity that it is compressing the lumen inside it. So there are large pleomorphic cells. You can see, because if there were not large pleomorphic cells like this, it would not have crowded the cells, and there is high nuclear cytoplasmic ratio. You cannot even look at the cytoplasm. This is just a blue ring kind of thing in here, right? So high nuclear cytoplasmic ratio is there, mitotic figures are there, so it suggests malignancy. Right here, it suggests malignancy. Mitotic figures like this. These are the mitotic figures right here. These are mitotic figures. That suggests malignancy. This is the case of malignancy. So let's see the stroma. There is pink fibrotic stroma around cancer cells, right? These are cancer cells. These are all are fibrotic stroma. This is due to desmoplastic reaction. Desmoplastic reaction is the reaction of the body or tissue to cover up the neoplasm. This is desmoplastic reaction. There is not much information because there are no infiltrating cells. There is no necrosis, so it rules out abscess case, and malignant invasion through fibrous breast tissue is there, obviously, like this. Here is the invasion, right? Are there any special features? There are no keratin pulse, so this is not a case of squamous disease. No mucin legs, so not mucinous carcinoma. There are no granulomas, so it is not a case of inflammatory. So it supports IDC, which is invasive ductal carcinoma. Let's talk. So let's integrate slide back with the symptoms. Now confirm. It is a case of middle-aged woman. There is a chronic mass. Slide shows invasive epithelial tumor disrupting architecture. So the diagnosis we reach is invasive ductal carcinoma. So that is how we tackle the question, right? This is a case of invasive ductal carcinoma. Done. Now, I have presented you the gift here. There are hallmark features of some diseases you have to remember. 32 diseases in there. So in Hodgkin lymphoma, the cells are Reed-Sternberg cells, which are binucleated or multinucleated cells with prominent nuclei. We also call it Wolff's eye appearance. And papillary thyroid carcinoma, the structures are Psammoma bodies, which is concentric lamellated calcifications. Concentric lamellated calcifications. And Psammoma bodies are seen in different lesions. There is mnemonics called Psammoma. We have talked about it in our general principles neoplasia. You can look at that. And the cellular feature is orphan NEI nuclei, ground glass nuclei. This is very specific. In medullary thyroid carcinoma, there are C cells as parafollicular cells with amyloid depositions in the stroma. And in squamous cell carcinoma, in various sites, there are keratin pulse in all sites. concentric layers of keratinized cells are there. In cross pathology, there is cauliflower-like growth in squamous cell carcinoma in all sides. And in breast cancer, like invasive ductal carcinoma, you can see glandular formation with comedonecrosis, increased necrosis within the tumor. This is a variant of invasive ductal carcinoma. There are different variants. And in ovarian serous cystadenocarcinoma, the hallmark feature is Psammoma, but is again calcifications. And malignant melanoma, the hallmark feature is that atypical melanocytes with pagetoid spread. This is pagetoid spread. Pagetoid spread is cells spread to the epidermis. This is what called pagetoid spread. And in neuroblastoma, there are flexner intestinal rosettes, rosette-like arrangements of small round blue cells around the central lumen. There is lumen in neuroblastoma, right? And ninth is choriocarcinoma. There are syncytotrophoblasts and cytotrophoblasts, increased human gonadotropin (SCG). And in glioblastoma multiforme, there is pseudo-palisading necrosis. Necrosis has a typical feature in this case, pseudo-palisading necrosis, like necrosis surrounded by malignant cells in palisade manner arrangement. And in Wynn's tumor, that is nephroblastoma, it is a tumor of children. And in a hallmark cell is blastemal cells, which are small blue cells with stromal and epithelial differentiation. And in the 12, there is clear renal cell carcinoma. So the hallmark cells are clear cells because there is abundant cytoplasm due to glycogen and lipids. There are clear cells present in the renal cell carcinoma. We'll talk about this in our today's study with me session of line to line USMLE first aid. So you can subscribe and join us in our daily sessions. We are going to crash the USMLE step 1 by having 260 plus score and getting what we want, right? So there is small cell lung cancer. The hallmark feature is salt and pepper chromatin, fine chromatin pattern, and neuroendocrine features are there. And in acute myeloid leukemia, there are all rods. These are very specific findings, like needle-like cytoplasmic inclusions are there. In chronic myelogenous leukemia, there is Philadelphia chromosome. That is translocation between chromosome 9, 22, and there is a fusion protein from BCR AVL. And in Paget disease of bone, there are osteoclasts with increased size and multinucleation. And in lung adenocarcinoma, the hallmark feature is glandular formations and mucin production in the tumor cells. In psoriasis, there is Munro microapsis. This is very specific features, that is the collections of neutrophils in the stratum corneum. And in rheumatoid arthritis, the hallmark feature is Panus formation, which is abnormal layer of fibrovascular tissue or granulation tissue. And in tuberculosis, there is caseating granulomas, but in sarcoidosis, there is non-caseating granulomas. This is very different. And necrotic center is there, surrounded by macrophages and multinucleated giant cells, that is caseating granulomas. And in non-caseating, there are granulomas without necrosis. There is no necrosis, but the granuloma is surrounded by lymphocytes. And in liver cirrhosis or chronic alcoholism, there are Mallory bodies present. So Mallory bodies are intracytoplasmic eosinophilic inclusions in hepatocytes. And in hepatocellular carcinoma, there are small and large polygonal hepatocytes with pleomorphic nuclei. And in neurofibromatosis type 1, like Schwann cells with neurofibromas. This is typical features. Schwann cells with neurofibromas is typical features. And another here is pheocytoma. Gel balloon pattern is the most specific feature for pheocytoma. There is rule of 10% for pheocytoma. Pheochromocytoma. We will talk about this in our endocrine pathology session. This is nest-like clusters of chromaffin cells, right? And in retinoblastoma, there is flexner Reed-Sternberg rosettes, that is radial arrangements of tumor cells around a central lumen, like this. There is radial arrangement of tumor cells. This is central lumen here. And in cervical cancer, there is obviously squamous cell carcinoma, is keratinization or keratin pulse are there. And in Ewing sarcoma, there is small round blue cells with rosette-like structures at diaphyseal location. This is also Homer-Wright rosettes. And Duchenne muscular dystrophy, we see muscular fiber necrosis with fibrosis and regeneration of muscle fibers. And in multiple myeloma case, there is plasma cells with clock face chromatin. This is very specific. Clock face chromatin in plasma cell dyscrasia like multiple myeloma. And also Russell bodies are there. Russell bodies are eosinophilic cytoplasmic inclusions. And in adenoid cystic carcinoma of salivary gland, there is cribriform pattern, which is Swiss cheese appearance is there. Swiss cheese appearance is there in adenoid cystic carcinoma of salivary gland. The last one we have is schwannoma here. There are a lot of other diseases like this, but I have put 32 of them to help you. And these are palisading arrangements of nuclei alternating with anuclear zones composed of cell processes. There are Antony A areas and Antony B areas, and they are Verocay bodies. So Verocay bodies, Antony A areas, Antony B areas are typical features of schwannoma. So this is how we complete how to read our pathology slides, right? And I hope this helped you. And if you are still here, thank you for staying, and subscribe for next high yield sessions that we will do in our upcoming days. Thank you, and subscribe for more, and then also share. Thank you.